Thank you very much.
This meeting is being recorded.
Thank you very much for inviting me, and it's a pleasure to speak about the topic of headache. Can everybody hear me? Is that okay? Or if there is any problem in hearing, then you could put it on the chat. So we're going to break this topic into three sections. Firstly, about the clinical features, then we'll take some questions. Then we're going to talk about the current management, and we can then break it into a little break for the question. And then finally, some newer treatments coming out. So that would be the third and final bit. I have to disclose my interest with the industry and other organizations. So we're going to talk about causes and diagnosis of migraine and the migraine types, referring migraine to secondary care. So that will be the first part of it. The second part would be managing migraine in primary care. And then the third part would be the emerging treatments. So you probably all know that headache is the most prevalent symptom and the most common neurological symptom in both primary and secondary care. And we basically divide these headaches into primary type, which means that there is no underlying cause for it, and the secondary headache, which means that there is an underlying problem that manifests itself as a headache. So my prime aim today would be to just include the primary headaches, which you come across quite often. And finding a secondary cause is often like a needle in haystack, because 99% of headaches, what you see in primary care, are primary headaches. And the most common types are migraines, tension headaches, a headache called trigeminal autonomic cephalalgia, a difficult name, but the most common type that you usually see in primary care is cluster headaches. And then there are other primary headaches, and some of them are fairly common, so I'm going to highlight on those. Secondary headaches is the four major ones that usually bother everyone is either a brain tumor or a subarachnoid hemorrhage or meningitis or encephalitis and temporal arteritis. Every primary care and secondary care are worried about whether somebody coming with headache may have one of these four causes. And once you have excluded those four, then the rest is all primary headaches. So the most common secondary headache is usually that you would see is like problem, they need glasses, they have a problem with the sinus, they have a problem in the jaw, or sometimes they get due to high blood pressure. These are something that are very obvious, most of it, and obviously you guys have got a very high sort of suspicion about it as soon as people come with a headache. But the main thing that people worry about is these brain tumors, subarachnoid hemorrhage, venous sinus thrombosis, and encephalitis and arthritis. So let me speak a few seconds about each of them. So subarachnoid hemorrhage is the worst ever, first ever headache, like somebody hit you with a cricket bat. Cricket is very important because currently there is a series going on between England and Pakistan. So if you feel like that the headache is hitting with a cricket bat, sudden onset, that unless proved otherwise is a subarachnoid hemorrhage. So that needs to go to A&E. Recent onset of headache with no previous history, which is gradually getting worse, raise you a suspicion about whether they have got any space occupying lesion or tumor. Young female, particularly overweight, smoker on oral contraceptive pill, think about venous sinus thrombosis with a new onset of headache, headache associated with altered awareness or consciousness, or any neck stiffness and fever, think about meningitis and encephalitis. Temporal arteritis is new onset of headache above the age of 60. Usually you read about 50, but mostly it is seen above the age of 60. Recent onset of headache, unless proved otherwise, think about temporal arteritis. So that's the common, uncommon but sinister causes. And the primary headache that you basically deal every day, and about, we think 95% of all primary headache disorders are managed in the primary care. So it's very few that get into the secondary care. They are mainly migraine, tension headache, and cluster headaches. So how do we, in our mind, classify them or remember them? So if people are getting headaches on say less than 15 days a month, usually it's around 10 or less than 10 days a month, we call them episodic. If they are more than 15 days, and usually it is about 20, 25 days a month, you call them chronic. So we have episodic primary headache, chronic primary headache. Then the type of headache. So people say that, oh, I get a headache which even if I don't treat it, goes away within a couple of hours, i.e. less than 4 hours, then you call them a short duration headache. And the reason it is important to remember is that cluster headache, which is often misdiagnosed, the cluster headache never lasts for more than 30 to 60 minutes and a maximum of 3 hours. So if the pain settles without treatment in less than 4 hours, think about a short duration headache like cluster headache. If the headache goes on for more than 4 hours, then you think about is a long duration headache, which is likely to be migraine or tension type headache. Now, the thing is that untreated. So if you take triptan, then every headache would go away within a couple of hours. But that's not a short duration headache. So short duration means untreated, it goes away. Now, always think about whether their headaches are related or associated with medication overuse. Now, people used to make fun that my painkiller are causing me headache, but now I think in the last 10 years, NICE has come out with the medication overuse headache. So a lot of people now realize and agree that frequent intake of painkillers can give them a rebound headache. So ask them, how many days a month are you taking painkillers? And that doesn't mean that the prescribed painkillers, but over the counter as well. Remember, most of the over-the-counter painkillers we have in the UK have got codeine in it. Sindol, Solpadeine, Capaic, they all have got codeine in it. And codeine is quite a bad analgesic to cause rebound headache. So ask them, are they taking any over-the-counter painkillers? Now, most of the people would not tell you that they are taking frequent painkillers. And the usual answer is, oh, I don't like taking painkillers. But ask them repetitively, how many days do you take painkillers? They say, oh, I'll take it whenever I have a headache. But how often do you get a headache? Oh, I get a headache every day. Does that mean you take painkiller every day? Oh, I don't like taking it. So you have to get it out from them. Because if they are taking painkiller on more than 15 days and triptan on more than 10 days, then likely that their primary headache may be complicated with a rebound headache. Now, if people have episodic headache, i.e. about 10 or less than 15 days or mostly around 10 days a month, then it is likely to be migraine or tension headache of the episodic variety. And also it could be cluster headache, but then you need to differentiate whether they disappear untreated within 4 hours or not. If they have got headaches on more than 15 days a month, usually about 20, 25 days or every day, then you are dealing with a chronic primary headache disorder. And the most common type of chronic primary headache disorder is chronic migraine. There are some chronic tension type headache. There are medication overuse or rebound headache, but the most common we are seeing is chronic migraine. So it is not a bad thing that if people say I get headaches every day, then it is, unless proved otherwise, is a chronic migraine. And it may or may not be associated with medication overuse. Now, some people do get chronic cluster headache. So they have cluster headache every day. And therefore, they could be fitting into the chronic daily headache disorder. But in this case, they would have many clusters each day, but each cluster episode would not last for more than 30 to 60 minutes. But we can separate them in the short duration and long duration. So in primary care, if you have come across somebody whose headaches come and go fairly quickly, then three most common reasons for that mainly is the cluster headache. So the cluster headache would come, last for 30 to 60 minutes. Even if they don't take a painkiller, it goes away. That's not as common but the problem is because it is very uncommon, it is often misdiagnosed. So cluster headache is where you get unilateral pain, excruciating, i.e. not severe. Migraine is severe, but not excruciating. So cluster headache is excruciating, always on one side, unilateral, around your orbit and eye, with watering of the eyes, bloodshot eyes, and runny nose, so autonomic features, maybe slight droopiness of the eye, often waking them up in the early hours of the morning because they have got good diurnal variations, and they are excruciating. And people with cluster headache would not be able to sit still or go and lie down. That's what happens in migraines. People go and lie in a dark and a quiet room. People with cluster headache will not be able to sit still. It makes them so restless. So that's how you recognize cluster. Now, ice-pick headache, also called primary stabbing headache, you come across quite commonly. Everybody gets it. Even I get it. It's like somebody has put an ice pick in your head. It comes and goes away within a few seconds. It's called primary stabbing headache. Amitriptyline is a very good treatment if it comes quite frequently. So it's ice pick headache is very, very common. I haven't come across anybody who never got an ice pick headache. And the third one, which is a short duration headache, is neuralgias. And you would have heard of the most common neuralgia called trigeminal neuralgia, which affects the V2, V3 distribution of the trigeminal. And they are short, sharp, electric shock-like pains that come and go within a few seconds. If it is in the V2, V3 distribution, it's trigeminal neuralgia. If it's in the back of the head, it's occipital neuralgia. If it's deep in the ear, it's called auriculotemporal neuralgia. So basically, you need to recognize what a neuralgia is. I mean, I get quite a few people who are referred as neuralgias, but I think the reason that neuralgias are often misdiagnosed is because people don't realize what neuralgias are. So they are very short, sharp stabbing pains, like an electric shock. If they untreated goes on for longer than 4 hours, then obviously you've got migraine, tension headache, and they are all associated with medication overuse. So this is one way of remembering them. So secondary headache disorders, primary headache disorders. Primary headache disorder that lasts for less than 4 hours, i.e. cluster headache, neuralgias. Longer than 4 hours, migraine, tension headache, and medication overuse. And as I said, unless proved otherwise, they are all chronic migraine, because that's 90% of the chronic daily headache. Very few are chronic tension type. And new daily persistent headache is actually chronic migraine, but it has got a very well-defined onset. So people would say to you, oh, I woke up on Christmas Day with a headache, and since then it has never gone away. So it's a new daily persistent headache. Now, the reason that it is called a separate entity is because recent onset of headache that goes on every day, you need to investigate. So that's why we put it separately. Otherwise, they are all like chronic migraines. So how do you recognize migraine? Well, recognizing migraine is that it's throbbing. So I feel as if my heart is in my head. That's how people describe it. It can be on one side, it can be on both sides. There is extreme sensitivity to light, sound, and smell. People want to sit still, they want to go and lie down, they avoid physical activity. And unless they take an analgesic, it would continue beyond 4 hours. So that's how you recognize migraine. And as I mentioned about cluster is also pulsating and throbbing, but it's almost always unilateral on one side. They may or may not have sickness and sensitivity to light and sound, but they are not exacerbated with physical activity. they actually get relieved with the physical activity. So that's why people are very, very restless. And whether you take a painkiller or not take a painkiller, they'll disappear within 4 hours. You will wake up at night in the early hours of the morning, and there are autonomic features, but it is a strictly side lock unilateral headache. What are the different types of migraine? Well, a third of them get neurological symptoms before the headache comes, and they are called migraine with aura. And majority, 70 to 80%, have got pure headache, but no aura, so that's called migraine without aura. Formerly, they used to be called common and classical migraine. The other one is the aura, but no headache. And that's usually quite common in people above the age of 50. And those who have suffered from migraine all their life often get rid of the headaches, but the aura remains. And that's called migrainous aura without headache. And that makes it very difficult to differentiate them from TIA or ischemic event. And that's why the next slide I have put in. Now, people with the migraine aura, because the aura comes as the spreading depression in the brain spreads. So therefore, the neurological symptoms gradually progress. So you'll see that it starts with a small blob. The blob gets bigger and bigger and bigger and bigger, and then gradually subside. So if somebody says to you, oh, I saw flashing light, zigzag lines, and then after a few minutes, I got numbness in my hand. Then after a few minutes, I got slurred speech. Then after a few minutes, I got some thought process affected. They're talking about migraine. Stroke strikes you. Everything comes suddenly. And that's why the migrainous aura goes on, develops over a period of few minutes, resolves over a period of few minutes. The TIA develops suddenly and goes away suddenly. Also, in the migraine aura, the symptoms are positive, flashing, zigzag lines. In stroke or TIA, they are negative, loss of vision, loss of sensation, loss of speech type of thing. So that's one way of differentiating it. And obviously, young age, family history, that also would help you to differentiate between a TIA and a migraine. And usually the aura is visual. Very few auras are motor or sensory. Typical aura, zigzag lines. Some people say this is blurred vision. I probably got it now. Blurred vision. That's another one, typical aura. Okay, so let me go back to this slide. So as compared to migraine, tension type headache is like a head in a vice. It's like a pressure, dull aching pain. Now, obviously, some people think that there is no such thing as tension headache. It's just a mild form of migraine where you don't have the nausea, vomiting, and sensitivity to light or sound. But I think from primary care perspective, if people don't feel sick or get sensitive to light or sound, it's fairly reasonable to make a diagnosis of tension type headache. And as you know, that amitriptyline is a good drug for both tension headache and migraine. So let's go. So which migraines you want to refer to secondary care? Well, if you're not sure about the diagnosis, then don't hesitate to refer them. If they get aura and you think that aura could be TIA and you are not able to differentiate, because people don't read textbooks. So they don't tell you what's written or what I have told you. Sometimes even myself, I have difficulty in differentiating whether it's an aura or it's a TIA. So if you are not sure, refer them. If the aura lasts for more than an hour, that's very unusual. So that's fairly reasonable to refer. Aura without headache, if you cannot differentiate them with the TIA. If the aura is bilateral, so they get bilateral tingling and numbness, bilateral numbness in the face, bilateral visual symptoms, That's very unusual. So brainstem auras are fairly rare and not a bad idea to ask secondary care to confirm that diagnosis. People with chronic migraines, you can refer them. So chronic migraines means the patient getting headaches for more than 15 days in a month. But I would come into it, which chronic migraines can you manage in primary care and which chronic migraines you definitely have to refer to secondary care. I'll come it in a couple of slides. And if patients are overusing medication, and in spite of your advice, they have difficulty in getting themselves off, then they do make a referral for them. So chronic migraine. So chronic migraine is where people complain of headaches every day. Now, for research purposes, we say 15 or more than 15 days. A vast majority of these people would have headaches every day. The problem with chronic migraine is that it is often underdiagnosed because a lot of people may think that this is probably a psychiatric issue or psychology issue. But in the last 20 years, we have been able to recognize chronic migraine as a highly disabling form of headache disorder. And because the headaches coming on every day, they probably end up taking painkillers every day, and therefore they develop medication overuse. These are people that have got other coexisting problems: chronic back pain, fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome. All kind of things are associated with it. And it's very difficult then sometimes to differentiate what symptoms are related to migraine and what symptoms are related to other comorbidities. Large number of them overuse painkillers. There is no doubt that they have got a low pain threshold, but there is something you can always do to help them. You can see that a large number of consultations in the UK are for chronic migraine. So people, half of the people, 50% of the population with episodic migraines don't come to the GPs. They just take over-the-counter painkillers. So what you see in primary care, a large number of them would have the chronic migraine. Okay, so let's, before starting with the treatment, let's take some questions for a few minutes. Got any questions?
Hi, yeah.
Hi, yeah.
Go on. I was just going to say, I think what's a brainstem aura?
So brainstem aura is where your symptoms cannot be explained by a problem on one side of the brain. So usually brainstem aura would have slurred speech, dysarthria, dysphagia, numbness and tingling on both sides of the face, both arms, both legs. That cannot be explained with one side of the brain. So that's the brainstem aura. And some people do get brainstem aura, and that's sometimes very difficult to differentiate from an organic pathology in primary care.
Can you get the migraine aura but without an aura?
Oh yes, I mean, you can get headaches without aura, so that's migraine without aura.
No, I suffer, I don't get the headache, I don't get the aura, but then I go downhill within about 30 seconds and look like I've had a stroke.
You can get aura without headache, yes.
But without the zigzag lines and the blurring?
But you probably get sensory aura or motor aura. Yeah.
Okay, thank you.
Visual are most common, but some people don't get visual aura.
Thank you.
In terms of like visual auras, can people sometimes get things like pixelated vision? Because I've had migraines for a really long time, but whenever I've spoken to my GP and talked about like my pixelated vision, that's never really, I feel like that's never been picked up on as like an aura.
Well, there are 126 different types of visual auras have been identified. So anything can, and any type can occur.
Okay, thank you.
Okay, shall we move? Right, so let's talk about treating migraine in primary care, which we're going to do acute treatments, lifestyle measures, and preventive treatment. So first line preventive treatment can be initiated in the primary care. So let's say about general principles. You have to tell the patients that you can't cure it. They may have to learn to live with it, and you can only help them to learn to live with it. You have to tell them that this is not a life-threatening condition, so they're not going to die from it. So that makes an awful lot of difference. You have to tell them that I can discuss the treatments with you, and you need to decide and take control of your treatment. Make sure that they eat properly, drink properly, sleep properly, and work properly. And in rare cases, you could refer them for CBT or cognitive behavior therapy, but obviously we don't have it much available, so we don't use it much in the UK. But I think these are the main 4 things that you need to talk in the first few minutes about it. Getting the expectations wrong is the most common reason that people keep coming back, because they expect you to cure them, which is obviously not possible. What acute treatment you would give? Now, there are 2 ways of approaching it. You could either give them, start with the small, simple painkiller, so paracetamol, aspirin, non-steroidal, and if that doesn't work, go to triptans. Some people choose the best treatment from the first visit, which is called the stratified approach. So suppose somebody is getting 4 or 5 migraines per month, and each of them lasts for a day or 2. So that's about 8 days of lost productivity. You might want to start with paracetamol and non-steroidal, and if they don't respond, you might want to go on triptan. Somebody is getting 1 migraine attack per month, which goes on for 2 days. Well, triptan might be suitable for them because they're not going to be using it too frequently. People who have tried over-the-counter painkillers, well, you might want to go to triptan because most of the over-the-counter would have the ibuprofen or paracetamol in it anyway. So that's the 2 approaches we have. Stratified approach is much better because think about the most appropriate treatment from the very start. Make sure they don't get opioids. If they get opioids, tell them that this is not a good painkiller. If they still want to take it, do not take it for more than 2 days in a week, because the more they take, the more they develop rebound. If you use triptan, about 30% people don't respond to triptan. So give them 1 dose of a triptan. If they don't respond, give them a second dose. If they use the same triptan 2 or 3 times and they don't respond, change the triptan. Because failure of 1 triptan doesn't mean that the other one wouldn't work. But if they have tried 3 triptans and it hasn't worked, it's not going to work. So these are the medication which has got good randomized controlled trial evidence. They are in alphabetical order. It doesn't mean aspirin is better than tolfenamic acid, but these all have got a very good trial data available. So use paracetamol, aspirin, or non-steroidal. These are the various triptans that you got it available. They are all in alphabetical order, and all of them have got a good trial evidence that it works in acute migraine. You can choose whichever you like. How do you choose which triptan? Well, subcutaneous sumatriptan 6 milligram is the most effective. I would relieve the headache within 5 to 10 minutes. Nasal sumatriptan is good for people who have nausea and vomiting. And sumatriptan tablet 50 or 100 milligram is usually people's first choice. And that's a gold standard because that's obviously came first in the market. Now, some triptan have got a longer duration of action. and that's usually fluvotriptan, naratriptan, and alithriptan. They have got a longer duration of action. So if people say that their headache lasts for 24 hours or more, you might want to use the longer acting one. If you want a quick response, very good response within 2 hours, is alithriptan, rizatriptan, and amitriptan. If people have got side effects, then maybe choose something with a low side effect profile, which is fluvotriptan, amitriptan, and naratriptan. So these are a little bit of tips to what you would use. Now remember that a combination of a triptan with non-steroidal is quite good. And my approach is that I usually give them either ibuprofen or naproxen, along with a longer acting triptan, which is fluvotriptan. So the ibuprofen and naproxen would work within a couple of hours and would work up to 8 hours. Fluvotriptan would take 2 to 3 hours to kick in and would work for 24 hours. So my usual approach is naproxen or ibuprofen with fluvotriptan. This is a very good slide to know which one you want to choose. So these are number needed to treat for 2-hour pain freedom in migraine. You can see that for giving us sumatriptan subcut injection, you only need 2 to treat 1 patient. And you give a gram of paracetamol and you need about 12 people before you get 1 better. So the number needed to treat vary from which one you use. And you see that you have got the best evidence for zolmitriptan 10 milligrams, then rizatriptan 10 milligrams, then alithriptan 80 milligrams. And if you have this chart in your surgery, you basically decide which one suits best for your patient. So that's acute treatment. Now, coming on to preventive treatment. So when do you consider people to go on preventive treatment? Now, the usual consensus at the moment is that if people are getting bad headaches on 4 or more than 4 days a month, you should really put them on preventive treatment. And all the new treatment that has come out have been licensed for prevention when people are getting headaches on 4 or more than 4 days in a month. So if the headaches are mild to moderate, you might want to start when they get 6 or more days. If they are moderate to severe, 4 to 5 days. And if they are very severe, maybe 4 days. But less than 4 days of headache per month can be easily managed on as required painkillers. If you choose a preventive treatment, take consideration of whether they are female, pregnant, taking contraceptive pills, and the comorbidities, whether they have got asthma, diabetes, or ischemic heart disease. So take these first 2 lines into consideration before deciding which one you're going to put them on. Whatever you decide to put them on, titrate it gradually over a period of 4 to 6 weeks to 6 to 8 weeks. So maybe like if you're choosing propranolol, start with 20 milligram twice a day. Maybe after 2 weeks, go up to 80 milligram per day. Maybe after a month, go to 160 milligram per day if they are tolerating it. Maximum tolerable dose continue for about 6 to 8 weeks. And if it doesn't work, then it's not going to work. So then you have to bring them off that. If they do work, you continue them for 6 to 12 months. Some people continue for 6 months, some people continue for 12 months, and then think about withdrawing it after that. And if on withdrawal, the headaches do come back again, put them back on it for another 6 to 12 months, but you should try to bring them off every 6 to 12 months to see whether they really need it. The most important validated score for quality of life is HIT6, which we always measure or monitor in our follow-up clinics for migraine. So these are the range of treatments available for you. So we have got beta blockers and pizotifin. We got topiramate and apelin, anticonvulsants. We got tricyclic antidepressant. We got lisinopril. We got candesartan. There are others, like the onabotulinum toxin. Methisargide is no more available. Flunarizine, which is only available from secondary care, And then some people find good with magnesium, riboflavin, and coenzyme Q10. So my usual recommendation is for everyone to take some supplements of magnesium, riboflavin, and coenzyme Q10. It is available as a single tablet called Doloent in the health shops, and they could try that one. So that's 3 are there anyway. Now, which one you choose out of them? Now, I must tell you that candesartan is not recommended by NICE, but it is recommended by BASH. It is recommended by SIGN guidelines. The reason that NICE does not recommend it is because the trial was done as a crossover trial. So the crossover trial is where people put people on propranolol, and then they put them on candesartan. And some people they put on candesartan, then put them on propranolol. So NICE doesn't like crossover trial. They like to have head-to-head trial with 2 running at the same time. So NICE is not keen on crossover trials, so they didn't even consider it when they were developing the guidelines. BASH and SIGN guidelines are evidence-based, and is recommendation for that. Lisinopril, not that much, but it's not licensed either anyway. Having said that, the amitriptyline is also not licensed, but it is used quite commonly. I would not use Apelin, particularly in young females. And topiramate can be used. So these are the range of drugs that are available. Now, how do you decide which one to go for? Now, the first line treatments for all of them, these are in alphabetical order. So amitriptyline, candesartan, propranolol, and topiramate, and Botox, they are all for chronic migraine. Apart from Botox, all the other 4 are for episodic migraine. These are the drugs that have got good evidence that they work as a preventive treatment. This is what is, these 5 are recommended both by the BASH and the SIGN guidelines. So in sitting in primary care, what would you go for first? Well, I go for either propranolol or amitriptyline. If the patient doesn't have asthma, I use propranolol as a first line. If the patient has got asthma, I use amitriptyline as a first line. When you prescribe amitriptyline, you should tell them that it was discovered for depression 50 years ago, but we don't use it for depression now. We have better drugs for depression than giving you amitriptyline. So I'm giving you for migraine. What if one of these 2 or both of them don't work? I tend to go for candesartan. And the reason behind it is that topiramate is very teratogenic. Plus, the topiramate side effects are very bad. People can't think straight, they lose memory, they feel like a zombie. So my next choice is usually candesartan. So propranolol, amitriptyline, candesartan, and if necessary, you can use after that topiramate. However, if you fail these 3 drugs, propranolol, amitriptyline, candesartan, or any of these 3, then really you should be thinking about Botox or CGRP monoclonal antibody, which are both approved by NICE. Now, because both of them can be done in secondary care, it's fairly reasonable that if you have got a patient with migraine or chronic migraine who have failed 3 drugs, is to send them to secondary care because they will be given either Botox or CGRP monoclonal antibody. What do we do in secondary care when the patient comes to us? If they have failed 3 drugs, if they have got chronic migraine, we give them an option of either Botox or CGRP. If they have got episodic migraine, we give them CGRP. If they have tried and failed Botox or CGRP monoclonal antibody, we go for nerve block. I'll talk about it in a minute. We can either suggest them some gadgets, or we can suggest them some IV dihydroergotamine, which is only available in tertiary care centers. So let's talk about each of them. Botox. So they failed 3 drugs. You give them 2 cycles of Botox, 3 months apart. If both cycles have not worked, then they're not going to respond. So we put them on CGRP. If they decide to go for CGRP, we do exactly the same. So we give them option of either going on Botox or we going on for CGRP monoclonal antibody, and anyone fails, they go to the other. So I asked them that they either choose Botox, and if that doesn't work, go to CGRP, or they could start with CGRP, and if that doesn't respond, go back on Botox. If you use Botox, you give 2 cycles, and if they don't respond, then you have to stop. If they do respond, you go on giving them every 3 months for as long as they come down to low episodic migraine, i.e. less than 8 days of headache per month. Some people take 1 year, some people take 2 years, some people take 5 years, and some people never ever get rid of Botox. So I have got people, 25% of the people stop Botox after 1 year, 50% people in 2 years, 75% people in 5 years, and we have 25% of the people who are on treatment with Botox for the last many years, 8, 9, 10 years, but probably lifelong. CGRP monoclonal antibody came in the last couple of years. We got 4 of them. We got Actinizumab, which is not currently available. It's still going through the trial and NICE appraisal, but 3 are available. We got Adalimumab or Aimovig from Novartis. We got Emgality from Lilly called Galcanezumab. We got Ajovy from Teva, Framazimab. All 3 are exactly the same. The Ajovy or Framazimab, you have an option to give every 3 months. Otherwise, all of them are used on a monthly basis. The Aimovig or Adalimumab work on the CGRP receptor, so it goes and blocks the receptor. The Galcanezumab and Framazimab work on the CGRP molecule and block the ligand itself. So we got these: Emgality, Ajovy, and Aimovig. Which one you choose is entirely the choice of the secondary care physician. Because Framazimab or Ajovy came first in the market and first approved by NICE, we use a lot of Framazimab, but we also use a lot of Galcanezumab. So what's the benefit of using CGRP monoclonal antibody? Well, we usually measure things by 50% responder rate. So these, I know the slide is not very clear, but we got Actinizumab here, Adalimumab here, Framazimab here, Galcanezumab here, Botox, and Topiramate. If you look at the 50% responder rate compared to placebo, they all have got better. So the evidence of 50% responder rate for all these new drugs, Botox and Topiramate, is exactly the same. What is more important, if you put people on Topiramate, about a third of them would not continue because of the side effects. If you choose people to go on Botox, only 2 to 3% would come out because of adverse event. If you choose CGRP, only 1 to 2% would come out. So this means that these new drugs, Botox and CGRP, are much better tolerated and much better outcome. But obviously, because they are very expensive, you have to try 3 drugs before you go on to these options. What if they don't respond to Botox and CGRP? Then we give them a nerve block. And it's a very good treatment, nerve block, basically giving a combination of some steroid and local anesthetic in the greater occipital nerve in the back of the head. And there are small trials, and it is a good bridging treatment. So if you are putting people on some preventive treatment that you want to see whether they get on, until that treatment works, you can give them the nerve block that would, about 50% people get about 50 to 60% better. Okay, so that comes some of the gadgets that you might have heard about. So you've heard about the transcranial magnetic stimulation, gamma core, Kefali, and Relivion. All 4 of them are available. The first 3 have been approved by NICE, but the NICE approval for gadget is not associated or is not accompanied by approval of funding. So therefore, there is no funding attached to it. So people have to buy for themselves or subscribe for themselves, and they are expensive. That's why I don't want to talk in detail about it, because even secondary care can't prescribe, so definitely primary care can definitely not prescribe. So what do we do in very difficult cases where people have tried everything and nothing works? Well, I usually send them to either Stoke-on-Trent or London for IVDHE. So IVDHE is like rebooting the computer. So if your computer doesn't work, you reboot it, it starts working again. So what the people think is that if none of the preventive treatment is working, there is a good chance that if you give them dihydroergotamine infusion every day for 5 days as an inpatient, those preventive treatment that were not working before can start working. So I usually send them to 1 or 2 centers, because there are not many centers who are doing it. So I give you a little pause again before I go for the emerging treatments. What new treatments are coming in the next 6 to 12 months? I can take question now, or I've got only about 2 or 3 slides, that you can take the question at the end. It's entirely up to you.
Can I just ask, I'm sort of 52 now, and I never suffered with headaches at all my life until I got to perimenopause. Mm-hmm. And now I'm moving more into the menopause state, and that's where I'm getting the headaches. What would you recommend treatment-wise for that, please?
Well, it depends how often are you getting it?
Quite often, but I'm not sure if it's rebound from opioids or not.
So which opioids are you taking?
Cocodamol.
Cocodamol. How many days a month you take?
About 15, I think.
So there's quite possibility that you may have a rebound headache. So the best thing to do would be to stop the opioids.
Okay.
Go on to naproxen 500 milligram twice a day for 2 weeks.
Right.
And see what happens. See what happens. And if it doesn't settle, then you would need some form of preventive treatment.
Okay.
If you've never had headache all your life, it's a good idea to scan, because onset of migraine in 50s is very unusual.
Yeah, I was about 38, 40 when I started to get headaches. And then bad ones as I got into perimenopause.
38, 40 is fine. Then you don't need a scan. I thought it started after 50.
Yeah, thank you.
Okay, if there are no questions, I'll take it at the end then. So what's coming in the next 1 year? Well, I mean, if I go back to 90s, we only had, well, if you go back to 80s, we only had aspirin, paracetamol, and ibuprofen. Then came the triptans in 90s. And then there was a 20-year gap where nothing came. And then in 2010, Botox came. And then in 2019, we got the CGRP. So it's progressing very rapidly, because we got 2 or 3 new drugs coming in the next 12 months. So one of these is a lasmiditan. So you know that triptans work on the 5-HT1, B and D receptor. And 5-HT1B is in the heart, and 1D is in the brain. So when people have ischemic heart disease, you're told not to prescribe them triptans, because they can give you coronary vasospasm, and people have stroke or IHT, don't give them. So lasmiditan is a further development of the triptans. They work on purely 5-HT1F receptors, which are only present in the nervous system. So they do not have the side effect of angina, or they don't have the contraindication in ischemic heart disease or stroke. So that will be available. This is available in America. It's got a very good efficacy similar to triptan, and it is good for people who can't take triptan. It's coming to UK in the next couple of years. It's already available in America. Then we are getting G-pens. Now, all the 3 G-pens are available in America. and coming in the next 1 year in the UK and Europe. So we got Ubrogepant. So Gepants are CGRP antagonists. So they are drugs that antagonize the CGRP molecule or the CGRP receptor. So Ubrogepant is for acute treatment. So it will be another option on people who cannot use triptan. They could either use the dietans that we in the previous slide, or they could use the Ubrogepant. The problem with Ubrogepant is if you look at the therapeutic gain, it's only 6 to 9%, triptan 16 to 21%. So therefore, if you can use triptan, you use that. If you can't use triptan, you may try the Ubrogepant. The second one, which is coming imminently, we have got a nice meeting in December, and it should be available by March, April next year, is Rimegepant. So Rimegepant is, the good thing about it is that it is not only an acute treatment, it's also a preventive treatment. So if you take it 1 tablet every other day, then you wouldn't need to prescribe any acute treatment. So it would work acutely as well as preventive. So have good progress, but look at the therapeutic gain is not as good. So again, Rimegepant would be reserved when you can't use triptans. And then the third Gepant, which is also coming next year, and NICE is appraising at the moment, is Atogepant. It's purely preventive treatment. And it is an oral treatment that you can take every day, and it would prevent you getting the migraine. So it would add another preventive option. This would add another acute and preventive option, and this would add as acute option, Ubrogepant. So that's all I wanted to update you on the latest progress. I think most of migraines can be managed in the primary care.